So really happy to continue our Grand Round series this month with my dear friend and mentor, Dr. Munir Janmohamed. He is an advanced heart failure and transplant cardiologist, did his training out of UCSF in San Francisco, and now runs the heart failure and mechanical assist device program out of Mercy General in Northern California. He is a social media maven, does a ton of social media education on cardiology, heart failure, also is a Doximity ambassador. He's a wonderful guy all around. He's going to be discussing a super important topic today, guideline-directed medical therapy in heart failure patients. So really excited to have you. Thank you for joining us, Munir.
Yeah, thanks for having me. You're very fortunate to have Ambreen. I've known her for a long time and seen all her progress, and she's a star. And so you guys
We
are very.
won't talk about the days of medical school when I used to not
Yes, I know. Yes, I'm not. I know that makes me seem really old, but I have some gray hair here, but I stay young at heart. So
Exactly. Key to life. So we have some, medical and a bunch of non-medical folks, here today. So I want you to just briefly go over what is guideline-directed medical therapy. We hear this mnemonic all the time. It's obviously, this hot thing that we've been talking about in the heart failure scene, your scene, but it's really become all of our scene over the past couple of years, not only in systolic, but also
yeah.
diastolic heart failure. So kind of just briefly go over what it is and what all the hype is about.
Yeah, I thought that maybe if I could maybe do this, I kind of made these slides kind of very simplified. So I don't know if I can maybe review these slides real quickly, then we can have discussion on those questions, or you want me to kind of
Yeah,
talk about, yeah.
yeah, if you want to go through your slides first,
Let's
it's totally
let's do
fine.
that, and then we kind of have a nice discussion then. So let me just share my screen here. Let me see here. Can you see this?
Yes.
Okay, great. So thanks for that question, Ambreen. So the title of the talk is Heart Failure Keys to Success, Not Failure, right? Words matter, right? And this is unfortunately a deadly disease, but now we have a major advancements, so we're going to talk about them. So as Ambreen mentioned, there's two types of heart failure. So heart failure basically means there's a disorder of the heart muscle, and there's really kind of two main types. So there's like a pumping problem, and then there's like a filling problem. So imagine you have like something in your yard, like a pump, it needs to fill with the volume and then needs to pump that volume, right? So we have something called heart failure with reduced ejection fraction, where the heart as a pump, it's not working very well. That's called heart HFrEF. And then you have problem with the relaxation or something called HFpEF, where it's not filling properly. So it's important to understand these two different types because you need to identify what type are you treating. And when you identify that, you can come up with certain treatments. So that's laying the foundation there. And then, why do we care about heart failure, right? Because the prevalence is increasing. This is the recent statistics and basically showing that patients are living longer, and they're living longer, unfortunately, with heart failure as well, too. And I didn't mention for the scope of this talk is that there's a high also symptom burden to our patients with heart failure, and also economic burden to the healthcare system as well, too. And also, not only is it a symptom burden to our patients, but it's actually a very high mortality disease as well, too. And this is basically showing here on this graph here, 5-year mortality of both the two types of heart failure. We always think the patients with the low ejection fraction, of the heart not squeezing well versus the normal one, that maybe the one with the weaker heart is going to have a higher mortality. But actually, both of them have very similar mortalities, and they're almost split evenly, 50-50. And the mortality is about 50% at 5 years. So the clock is ticking when patients are diagnosed. And this is my dad. This is the original Dr. J. This is at my graduation. He's a retired physician. He retired about 10 years ago. And, this is my dad's old doctor bag. And back in the day, he had these bags, and I'm lucky enough to keep this bag, and I kind of use this bag in all my talks, right? And so what tools did he have in his bag versus what I have tools in my bag to management of heart failure? And I like this slide. I created this slide actually looking at all the different tools I have in my tool bag. When I see a patient, I have so many advances in the treatment of heart failure. I'm going to focus on heart failure with reduced ejection fraction, where the heart is not working as a pump. So I'm not going to go over all these, but kind of make it very simple. So the first one, these are the so-called quad therapy. We want to go on the next slide. The 4 therapies that we use that have been shown to improve patient symptoms, improve outcomes as well too. And then you have these devices such as a defibrillator. You may have seen at the airport where they have devices, because these patients have high risk of having sudden cardiac death. So we have implantable defibrillators. And then Dr. Mohamed or Ambreen is actually an expert on imaging. Some of these patients have very leaky valves, and so sometimes they have to get a procedure to fix this leaky valve. It's called mitral clip. And then we have remote monitoring. As cardiologists, we're super nerdy, and we have these devices to kind of track how much pressures patients have, something called CardioMEMS. And then the end of the spectrum is you have sometimes patients need something called an elevator heart transplant. And we can't forget sometimes patients are not candidates for any of these therapies, and you have to think about palliative care and comfort care. So many different tricks I have in my bag, which are very different from my Father's Day. I really love this slide. This is a really must slide. We have to keep in mind, is this polypharmacy? Breen talked about the 4 therapies, quad therapy. Now we got to remember, when I see patients with heart failure with reduced ejection fraction, they don't just have heart failure. They may have heart disease. They may have atrial fibrillation, multiple cardiac condition. They may have diabetes. So this is a lot of medications, right? So I have 4 I'm talking about for my heart failure. They may have a couple for diabetes. Is this polypharmacy? And this actually is looking at incremental benefit of all the different therapies, right? And if you add these 4 therapies, so-called quad therapy, you have a 61% improvement of all-cause mortality. That is huge, right? That is a big impact on our patients. So this is not polypharmacy. This is additional mortality benefit to our patients. And it's not all or nothing. So if, let's say you can't get on all these 4 medications, let's say you add 2 instead of 3, there's still incremental benefit. So this is really key. And then, as Ambreen mentioned, I'm a big on social media. I'm also a big sports person, and I love my 49ers. You can see all around me. But these are I call the goats of sports. You may disagree with these goats here, and I'm a 49er fan, but I give Brady his credit. But no one's going to debate. These are the 4 therapies, the best therapies we have for heart failure with reduced ejection fraction, where the heart's not squeezing very well. So something called ARNIs or sacubitril valsartan or Entresto. You may have heard about that. Something called beta blockers, MRAs, and SGLT2 inhibitors. These are the 4 so-called quad therapy. And we also have now therapies for the other type of heart failure where the heart's not relaxing normally. This is the first approved therapy in 30 years, just came out last year, something called SGLT2 inhibitors, really amazing therapies. So as Nike says, just do it, right? All right, so this is kind of like my Instagram world, right? But we all know that Instagram versus reality is very different, right? So we have a vision of kind of how we see things, and then there's the reality, right? So what's the reality, right? So the real world treatment of heart failure with reduced ejection fraction. This is where the heart is not squeezing very well, and we have all these great therapies, the quad therapy that I'm being talked about, right? So this is actually patients admitted to the hospital for new onset heart failure with reduced ejection fraction. The heart's not squeezing very well. And out of that, basically, 4 out of 5 patients were eligible, 82% for these therapies, right? But despite that, only 1 in 6 prescribed it, right? We're not doing a good job. And you can see here the absolute risk reduction with all these therapies. So, and I really like this. This was someone, I won't take credit for this one, someone on Twitter commented, time is yours lost, right? Every time we see a patient, every time a patient touches some person's, whether it's a hospice or it's a nurse practitioner or a PA or a heart failure cardiologist or Ambreen or whoever it may be, that's an opportunity to change the trajectory of this patient, right? So we need to act at that time. Don't wait and don't push it off to the next person. And so this is actually, so I work, I work for a group here called Mercy Medical Group, and we're part of a large organization called Common Spirit. It used to be a Dignity Health merged with what's called Catholic Health Initiatives. We're quite of a large organization now, providing almost about 20% of cardiovascular care in the country. And so they had this kind of goal looking at heart failure in 2023. And really the goal was, to quickly summarize this, was to reduce inpatient mortality and heart failure readmissions for patients admitted for all types of heart failure, both types we talked about, right? And kind of using a metric, something called the observed versus expected mortality, and using certain risk calculators based on the MIDAS risk calculators. And this was based on implementing the guidelines from the 2022 guidelines. And really the goal was to focus on readmissions and then obviously hopefully make an impact on mortality and best practices as well too. So how do we do this? This is quite a large task, right? So we kind of had this kind of summarize. This has been a year kind of work, but first of all, we started with education. We have to educate everyone, right? We have several lecture series, and we have actually one tomorrow. And the purpose of the lecture series, we have from different perspectives, right? As I mentioned, different touch points. So I did one lecture, but I'm not the only one taking care of these patients. So we had one by pharmacists, we had one done by hospitalists. Tomorrow, our webinar is actually all of us, a patient that's come in the hospital, sees hospital medicine, and then sees pharmacy in the hospital, sees primary care in the hospital, an outpatient, and then sees me as well too. And so different, so lecture series by different people, so everyone feels comfortable with these medications, right? And then obviously, scorecards matter, right? So sometimes when you see how you're doing, you're like, we all been working very hard in our school, right? And you saw a bad grade, you're like, oh my God, I don't want to be embarrassed, right? So we got these scorecards. Everyone has their own scorecards and see how they're doing compared to their colleagues, right? So that really makes an impact. And then we develop order sets. And then really the important thing is ownership on all individuals, right? We got to change this mindset of saying like, oh, these quad therapy, okay, I'm going to have Dr. J prescribe that because that's his specialty. Everyone can prescribe these medications, right? You have become familiar with these medications. So I'm just going to quickly I'm not going to go over all these OR set, but this is just an example of an OR set we created. Unfortunately, we have Cerner, which is terrible, and they're all terrible, all these EMRs. But anyway, so this one actually came out kind of nice, I have to say. So you just type in congestive heart failure, and then you basically click what type you have, right? So we talked about the different types, right? The heart failure with reduced ejection fraction versus preserved ejection fraction. So you just click this, so simple. Click what you're dealing with, right? You got to know what you're dealing with first before you come up with an algorithm what to do. In this case, this patient has heart failure with reduced ejection fraction and has all these nice quad therapy, all this ready for you to click away, And so hopefully we hope that's going to help create awareness about what your goals are, right? And it's actually worked, right? And so this is our statistics, basically the ODA mortality, and this is based on a percentile. And I'll just focus your efforts on the right here. And so basically, our target was 56%. That was our goal. We started this around springtime of 2023. And you can see as an organization overall, we've dramatically improved, a 75% improvement. We can go into kind of what's the issues or how we've actually improved this, but I think definitely has to do with awareness and ownership on everyone to do this. So, how do we focus on inpatient care, right? So, I'm on the length of stay committee for the hospital, and when I joined about 2 years ago, the first day I told everyone, I said, listen, by adding me in this committee, I'm not going to decrease the length of stay. I'm going to focus on the care of the patient in the hospital. And that may increase length of stay, but either you pay the price now, you pay the price later, right? You got to focus, change your efforts. Patients come to the hospital for what? Symptoms, right? Shortness of breath. What happens is that they give a dose of diuretic in the ER, and patients say, I'm feeling better, and they go home. And oftentimes, statistics have shown patients' weight has not even changed. Sometimes it actually increases, and we've done nothing to change the direction of this patient. When a patient comes to the hospital, their mortality goes down. So we have failed this patient as a system, right? So we need to ask ourselves, what are we going to do to change the trajectory of this patient? So we came up with a simple, algorithm to what to do, and we're going to talk about this tomorrow. So first of all, you want to make patients feel better. You want to implement the patients on these GDMT in the hospital, right? The hospital is the perfect time to do this. You have all these multiple vital signs and labs. That's the time to do it. They're being watched like a hawk, right? So that's the perfect opportunity. But we need to change our mindset. We always think, oh, these meds aren't safe in the hospital. We got to provide education to our patients. Gone are the days where you basically prescribe a medication into your patient, say like, here, take all these 4 meds. You need to empower your patients to understand their disease and buy into the system, buy into the treatments. That really makes an impact. And then obviously you have to make sure the transition to outpatient setting is smooth. So we're very fortunate we have a TOC pharmacist, but you have to come with the system in place. How do you transition to outpatient and do a handoff to the next team member, which would be the hospital medicine or cardiology? I'm almost done here. So this is actually a sample case. I think it's very powerful. See a picture, and so Breen's an imager expert. And so on the left here, this is basically what's called 4-chamber view. And you can see here, this is what's called the left ventricle. We talked about the heart not pumping where normally, so you can kind of see if I put my cursor here. You can clearly see.
So I was gonna.
Sorry, Munir. Guys, if you're unmuted, please mute yourselves.
So you can clearly see on this image here that her heart is not working very well. And then this is actually after 4 medications. You can see the heart is smaller, first of all, and you can see the heart is definitely squeezing much better. So pretty impactful with simple medications, not as sexy as procedures, but that's all this patient needed. And this is that patient actually, right? So this is actually a patient that spoke to at our symposium about 2 years ago. And, she actually had some really nice words for me. When she was first diagnosed, she has, you have heart failure, right? And words matter, right? And so now we actually have now tools that to achieve success. Now we don't have a cure for heart failure, but we have major advancements. So thank you for your time.
That was awesome. Thank you. All right, you want to stop sharing?
Yes. Do this. Let me see here. Here we go.
Okay, cool.
Perfect. All right, great. I'm
All right,
answering.
wonderful.
Yeah, go ahead.
That was wonderful. So we still have a couple minutes left. So I just wanted to ask you a couple questions. So obviously you work in the inpatient setting. And, you're seeing patients when, they are presenting, like you said, with symptoms. And then, after you help minimize their symptoms, then you're talking about initiating, therapies, making sure that they have a smooth transition as an outpatient, and then, continued follow-up, not only with you as their primary cardiologist or heart failure specialist, but also, with their primary care physician. Now, us, on the other hand, we're in the virtual space, and so we see outpatients. And so one of the struggles that I see, not only in this space, but I've worked in clinics and such, prior to this, is that we're dealing with a lot of primary care physicians who maybe don't feel comfortable with GDMT.
Right.
Or even some of us who, sometimes because, the patient might be a little bit more complex, or it's new onset heart failure, or it's even diastolic dysfunction, because I feel like we're really not doing well in that department all around. How do we kind of overcome some of these, challenges? Like, how do we help our primary care colleagues, or how do we ourselves become more comfortable with, okay, I'm okay to start these medications. Is it more of a trial and error? Do we start everything at once? Is it more of an open conversation? Like, what kind of ideas do you have? And also, to kind of piggyback off of that, when do you think is the best time to refer to a heart failure cardiologist? Because I talk to a lot of you guys all the time, and it's always early referral is the best thing. But do you think like a general cardiologist can just manage heart failure until someone becomes like super sick? Like, I know it's a lot of questions, but would love to hear your thoughts.
Right. Yeah. So I think your first question about, how do you, for primary care, or let's say people aren't as comfortable to managing these things. So first of all, you have to know, first of all, what are you treating? And I know it sounds so simple, but sometimes I see all the time, so it's not very clear what type of heart failure you're treating. Once you kind of know what type of heart failure you're treating, in your mind, you can think is like, okay, what medication should patients be on? And, as far as for, familiarity with these medications, I think that it's challenging. I definitely agree. I can give all these lectures all I want, but ultimately someone needs to feel comfortable doing it. So I will say that there's a new document that came out by the ACC. It's kind of consensus document on management of heart failure. It kind of gives some tips, right? If you're concerned about, let's say, hypotension is a concern that oftentimes people have starting these medications, they kind of give you some suggestions which medications to start. So that's very, very practical document. The other thing too is I can't forget as well too, some of the lack of the inertia is these medications are challenging, which means to get access, right? And so they do mention as well too, knowing the different resources. So I know that I came from academia to private practice, and I don't have a whole team of people to help me, get all these medications. So I had to become very efficient in my care, right? So I met with all the different industry people, and I say, okay, what are the resources you have? And I have a Google Drive with all these different documents, so I kind of know where to look to provide those resources for my patients, right? So I think that, like, as a cardiologist or a primary care, if you don't feel comfortable, which may be the case, you got to refer to a heart failure specialist, right? Because if you're not doing it, someone needs to do it, right? So refer early. My threshold, I like to see the patients through the continuum, from the beginning and sometimes towards the end, and then sometimes work on medications, get to know them. And so I hope that answers your question.
Yeah, absolutely. I really love the initiative that you and your hospital system are a part of, and hopefully, obviously, we're already seeing trends in a good direction. You already briefly mentioned access to some of these medications, so like especially SGLT2 inhibitors are really difficult to access for a lot of patients. So I know you said that your specific hospital and the clinics that you work with have some resources and tools, but what kind of advice probably would you give to other, primary care physicians or cardiologists that are having some difficulty?
Yeah, Yeah, I will say definitely access is definitely improving because, now we have, these are now class one, which is the highest recommendation based on our society. So hopefully insurance companies will kind of, before, like when I was prescribing SGLT inhibitors, just to give you an idea for your audience, these were originally developed for diabetics actually 10 years ago. And they found out they're not very good diabetic drugs. They're actually heart failure drugs and also renal protective drugs. And before, sometimes when I request some of these medications, like 2 years ago, I'd say, is the patient been on metformin, which is a diabetic drug? And I'm like, well, this patient doesn't have diabetes. So now I'm seeing that insurance companies are recognizing these class of medications, the economic benefit and symptomatic benefit for our patients. So it's becoming much better. We have actually now three that are FDA approved for heart failure. So oftentimes, usually one of them is covered, and obviously, and also, Biden had a list of these top 10 medications that he's going to focus on with Medicare. We're a little biased, and Breen and myself being cardiologists, 6 out of 10 were actually cardiology medications. So hopefully and one of them was SGLT2 inhibitors. So hopefully that's going to help improve access too.
Yeah, Biden's key top 10.
Yeah.
So one of the comments was by Andrew here, who does not like your sports team affiliation. So I'm sorry about that.
Well, I hope he's not a Kansas City fan. Yeah. So.
And I
very much a
really
Kansas City fan.
uh,
I am very much a Kansas City fan.
You guys broke my heart. Yeah. Okay. Yeah.
Are you a Travis Kelce fan? Okay, just kidding. I'm not going to go there. So I wanted to open it up to the audience. If anybody had any questions, anything that they wanted to ask Munir, any comments?
Ron Green here, the sleep specialist.
Oh.
Yeah, so I was fortunate enough to give a grand rounds quite a while ago with Heartbeat on heart failure and cardiovascular complications of sleep apnea, and treatment decreases mortality very significantly, and north of 70% of your patients have obstructive sleep apnea syndrome. So I saw your little bag with all your tricks in it, and that was one thing that wasn't in your bag, and I'd want to hear your comments about that.
Yeah, no, very, very good. Well, yeah, I definitely screen, particularly for the HFpEF. So the patients that are the normal ejection fraction without squeeze of the heart, these patients tend to be older and more obese. And then so I often ask the screen question for all types of heart failure, daytime somnolence and, snoring at nighttime. A very, very good point. And to screen for sleep apnea. And if you have sleep apnea, treat it because it's just a treatment, just like all these medications that can actually have a benefit. And there's a lot of excitement on the role of obesity in heart failure as well too. For the sake of this time, I can't talk about that. But we've seen all these medications called Ozempic, and obviously we're hearing about the vanity stuff, but they're cardiovascular benefits. And you probably talked to Breen and I probably in 2 years, and we may be prescribing these medications ourselves, because we're seeing some studies coming out looking at the benefit of, and there's one that came out last year looking at HFpEF, which is the normal ejection fraction heart failure I talked about, looking at Ozempic in that group. So. More to come.
Yeah, thanks.
Anyone else with any questions, comments?
I will make one other comment to say, that, you guys as a tech company, I really feel like tech can help leverage, the management of this chronic disease as well too. I'll give you an example, just one, for example, telemedicine, right? Before COVID, there was this apprehension about telemedicine. Right now, we know that telemedicine is here to stay. It's safe. It's actually effective, right? And I'll give you an example. So I didn't mention as well too, when you start a patient on these therapies in the hospital, you can't say like, okay, it's come back in 6 months. You got to time is years lost. You got to titrate these medications quickly and generally every 2 weeks. So imagine if you're a patient and that the patient I talked about, she's a young woman and she works. And so imagine every time you come to the doctor's office, how long does it take you? It takes you maybe like 30 minutes to an hour to get wherever you're going to. You have to park. It takes sometimes like 2-3 hours of your day just to do a 20-minute appointment. Sometimes not even 20 minutes, like 15 minutes. And all you need to know is like, what's your blood pressure, what's your heart rate, what's your labs, and do a titration, right? So virtual visit can help, bridge that, right, and improve the care of a patient. So we're big on telemedicine here. And I think we're hoping to, push it to the next step, which is, new consultation, because there not maybe heart failure specialists in every city, but I'm able to do telemedicine all across the state. And then, maybe in the future, maybe AI, right? It's not that complicated what Ambreen and I do. We basically ask for a couple of variables.
Wait a second. I don't think an AI person can replace.
Yeah, I mean,
That's
we'll see. I mean, think. I mean, there's a couple. I mean, I'm just thought provoking. I mean, there's a couple stuff that I always ask, right? You know, like, and I gotta know to make an educated decision what to do next on that patient, right? And maybe that may kind of prompt, help, bridge this gap, because I've been giving lectures now for 10 years, talking about all these therapies, and we're not seeing much push in inertia, and how do we change that, and so we'll see.
Yeah, definitely, definitely. Well, thank you so much again. This was wonderful, and I'm so happy that you were able to talk to us about this. It's such an important topic, and yeah, thank you. Thank you everyone for joining us.
Thanks for your time.
All right, awesome.
Go Niners.